Endocrine changes in pregnancy, especially in thyroid function, is very common and interpretation is little confusing. Today I'll be discussing the physiological changes, the mechanisms and interpretation and two cases in relation to thyroid function and pregnancy. I am Dr. Andrews, Professor of Medicine and Consultant Neurologist. So let us look into the key points in thyroid physiology in pregnancy. As we know, the estrogens produced from the placenta increases the thyroid binding globulin synthesis. The thyroid binding globulin attaches to T3 and T4. So what happens in pregnancy? The total T3, T4 increases. That is the number one point to remember. The human chorionic gonadotrophin peaks at around 10 weeks. It has got an alpha subunits. It imitates the TSH. So what happens? This will stimulate the TSH receptors and will produce increase in the production of thyroid hormone. So T3 and T4 will increase. So one, because of the estrogen, by the increasing the thyroid binding globulin, total T4, T3 increases. Second is the first trimester, the HCG producing stimulation of the TSH receptor produces increase in the production of thyroxine. At the same time, it will produce mild suppression of the TSH. I will explain this with a picture. Third point to remember is that the glomerular filtration increases in pregnancy. It will produce release of iodine or iodine clearance increases. At the same time, the fetus needs iodine. And so the requirement of iodine increases. These are the three changes you should remember. So now we look at the hypothalamo-pituitary thyroid axis. Here the hypothalamus produces TRH or thyroid releasing hormone. The anterior pituitary produces thyroid stimulating hormone which act on the thyroid gland. And the T3 and T4 is produced which produces a negative feedback on the hypothalamus and anterior pituitary, and that is how the hormone synthesis is maintained. So here in a pregnant person, what happens? The placenta produces human chorionic gonadotrophin which peaks around 10th week or the first trimester and stimulates the TSH receptor. So it acts on the TSH receptor, and so what happens? The increase in the production of T3, T4 produces negative feedback and the TSH level comes down. That is why in first trimester the TSH level can be low. Increased level of estrogen will stimulate the liver and it produces increased hepatic synthesis of thyroid binding globulin. So the increase in the thyroid binding globulin produces rise in total T3 and T4. Hope the thyroid physiology is clear. So in pregnancy, the TSH level changes, total T3, T4 and also the free T3, there will be some changes. That is why in pregnancy there is trimester specific values, especially for the TSH. So usually it is taken as the Indian guideline. First trimester, the upper level of TSH is 2.5. And the second trimester and third trimester it is usually taken as 3. So even though most of the laboratories and normal TSH value is written as 4 to 5. Here in pregnancy the upper limit of TSH is 2.5 for the first trimester, 3 for the second and third trimester. So the TSH is little lower in pregnancy. I have explained what is the mechanism. So this is in summary Pregnancy is a natural stress test for the thyroid gland. There is increased estrogen in pregnancy. There is a 2 to 3-fold rise in thyroid binding globulin. So total T4 increases 1.5 times from the non-pregnant level. Second point I have mentioned, the HCG has got a similarity with the TSH. So there is a transient decrease in the TSH in the first trimester, and the TSH values are little lower than the pre-pregnant level, and usually you take the trimester specific cutoffs which we have already mentioned. There is increased peripheral metabolism of thyroid hormone, and sometimes the free T3, T4 can be decreased. So in pregnancy, the fetus up to the 10th week is exclusively dependent on the maternal T3, T4, because there is no production of TSH, and the TSH and TRS cannot cross the placenta. So the requirement of thyroid hormone is little higher in pregnancy. These points are clear to you. So I will explain a little more on the trimester wise THT changes. Typical laboratory pattern. First trimester TSH is often decreased. Total T4, T3 increased. Free T4 may be slightly increased or normal. That is in the first trimester. Please note it down. The second and third trimester TSH returns towards baseline, but can be little lower than the pre-pregnant level. Total T4 and T3 remain increased because of the estrogen producing rise in the production of the thyroid binding globulin. So total T3, T4 can be increased. So use trimester specific reference ranges when available. So this is clear. I will repeat once more the mechanisms behind the changes. Estrogen increases hepatic thyroid binding globulin, and total T4, T3 increases. HCG alpha subunit has homology with the TSH. Transient thyroid stimulation, decrease in the TSH in the early pregnancy. Increased GFR and placental fetal iodine uptake. There is an increased iodine demand. Okay. So interpreting TFTs and the treatment targets, the practical guidelines. Prefer pregnancy and trimester specific reference ranges. Don't think about the normal values. If unavailable, American Thyroid Association allows upper TSH limit as 4. But Indian guideline we have already mentioned, first trimester 2.5, second and third 3. When treating hyperthyroidism, aim for TSH in the lower half of the trimester range, or less than 2.5. Many women need 25 to 50% increase in the levothyroxine dose in early pregnancy. Recheck every 4 weeks after if any dose change is there. Common clinical patterns. One is the gestational thyrotoxicosis, that is low TSH, normal or mildly increased free T4, which I already mentioned. TRAB is negative, it is associated with hyperemesis, usually self-limited. So this is gestational thyrotoxicosis. The Graves' disease, if it occurs, there is the same, almost same value, but the TRAB is positive. So that is how you differentiate from the overt hypothyroidism. There is increase in TSH, decrease free T4, treat with levothyroxine. Subclinical, there is increase in TSH, normal free T4, treatment based on the TSH, and TPO antibody level. That we will discuss in another session on hypothyroidism. So we will take one case. This is a pregnant lady with a TSH low at 9 weeks, 26-year-old female, severe nausea and vomiting. TSH is 0.05, pre-T4 upper limit of normal, TRAB negative. So the TSH value is low. Interpretation, less likely to be gestational thyrotoxicosis. As explained, HCG will produce stimulation of the TSH receptor and increase the pre-T4. There is no need of antithyroid drugs here. Support the patient, treat the hyperemesis, no antithyroid drugs, recheck TFT in 4 to 6 weeks. This is another patient with high TSH at 12 weeks. 31-year-old female, 12 weeks gestation, TPO positive, TSH is 6.2, pre-T4 low. Interpretation, as the TSH is less than 10, you can consider it as a subclinical with thyroid peroxidase antibody positive. Here the patient has to be started on levothyroxine. Target is TSH less than 2.5 or lower half of trimester range. Pre-check in 4 weeks. If pregnancy-specific TSH reference ranges are not available, upper reference range, take it as 4. So in this session, we have discussed the physiological changes that occurs in pregnancy regarding thyroid and the interpretation of thyroid function. The next sessions will come with the hypothyroidism and hyperthyroidism in pregnancy. Stay tuned. Thank you.